Sritharan Kadirkamanathan. He's a consultant upper GI surgeon in Middlesex Hospital, Broomfield, Chelmsford, Essex, UK. And he's an upper GI surgeon in robotics, laparoscopic, and bariatrics. And he's interested in benign and malignant upper GI cancers. And also, he's one of the world experts in gastric pacing. And last not least, he's trainer of many of us as our overseas trainer, including me. Over to you, Sri, to talk about Barrett's and other pre-neoplastic lesions of the upper GI tract detection and management.
Chaturanga, thank you for the kind introduction. It's 4 a.m. in the UK. Anyway, greetings. Can you hear me at all, or just to check?
Yes, we can hear you, Sri.
Okay. So I think the first, I was asked to talk about Barrett's and other pre-neoplastic lesions of the upper GI tract. I thought I'll stick to the esophagus. And it's kind of a philosophical talk and with some data. Please feel free to ask any questions should you wish at the end of the talk. So Barrett's esophagus is a pre-neoplastic lesion, and it is associated with long-standing gastroesophageal reflux disease. In terms of managing any kind of pre-neoplastic lesions, the philosophy is similar. So I'll just mention the other esophageal pre-neoplastic lesions such as achalasia, tylosis, esophageal diverticulum, Plummer-Vinson syndrome, and post-caustic stricture of the esophagus, which is often seen quite a lot in Sri Lanka. I do remember papers on this caustic strictures where people drink caustic stuff from the rubber industry, I think, from memory, when I was a young doctor in Sri Lanka many, many years ago. So achalasia, just very briefly to remind you all, it's a primary esophageal disorder. The diagnosis nowadays is high resolution manometry. There are two abnormalities, aperistaltic esophageal body and hypertensive non-relaxing low esophageal sphincter. But the more important thing here to mention is that long-standing achalasia can cause squamous cell carcinoma of the esophagus. We do see patients in the UK in whom often we have to do 3-stage esophagectomies. But the key thing to note is that the annual risk is 0.18%. So it's an important number to note because this is in fact higher than Barrett's esophagus. Coming to tylosis, which is Hall-Evans syndrome. Now this is an inherited condition, autosomal dominant. Patients tend to get palmar and plantar keratoma. It can often manifest at the age of 10. And these people get squamous cell cancer of the esophagus from 20 years on. And the penetration is very high here. A lot of the patients will get, again, you need to be aware of this. And, you know, as part of the management of the pre-neoplastic lesions, you may want to investigate these patients further and do surveillance. With esophageal diverticular, again, you can get squamous cell carcinoma of the esophagus here. Again, look at the annual risk, it's 0.6%, much, much higher than Barrett's esophagus would be. Injury, caustic injury to the esophageal mucosa can cause squamous cell cancer again. It can happen up to 7% of the patients do develop cancer as time goes by. Plummer-Vinson syndrome, I remember this studying, I think in my physiology in the first year actually. Iron deficiency anemia, dysphagia, post-Cracovia web. Again, they tend to get esophageal cancer in the proximal esophagus, and they're quite often squamous cell cancer. I think what we will do is to look at Barrett's esophagus and how one would manage Barrett's esophagus in terms of surveillance and management. That will equally apply to the other conditions we mentioned before. As you know, Barrett's esophagus is associated with long-term gastroesophageal reflux disease. It's the commonest disorder of the upper GI, commonest upper GI disorder of the Western world. It is not uncommon in Southeast Asian population. It can be chronic recurring, often medical treatment, and a small cohort might require surgical intervention. Now, the reflux and the cancer pathway, just to remind you all, esophagus normally has a squamous mucosa. Long-term reflux can cause metaplasia to columnar metaplasia. Then one tends to get low-grade dysplasia, high-grade dysplasia, and subsequently cancer. So in terms of managing Barrett's esophagus, you want to catch it as they get low-grade dysplasia. And if you can treat at that point, in theory, you could prevent cancer formation. But there are problems. So the exact cause of Barrett's esophagus is still not really known. I mean, one of the association between gastroesophageal reflux and Barrett's esophagus was based on one single paper by Cameron from Mayo Clinic in 1992. What he showed was that patients who came for endoscopy with reflux disease, there was a proportional increase in the Barrett's as the age increased. Therefore, the assumption was that long-standing reflux progressed to Barrett's. However, there are papers suggesting Barrett's esophagus is seen in children. Equally, there are also papers suggesting that can it be caused by HPV virus? There are papers from Melbourne suggesting that it might be a possibility. However, at this moment in time, we all accept, at least to a point, that long-standing reflux causes Barrett's esophagus. We accept that Barrett's esophagus is an important surrogate marker of esophageal adenocarcinoma. And if you look at the annual risk, and remember the other ones I showed earlier, it's 0.12%. It's a lot less. However, the risk increases in the presence of dysplasia. So it's five-fold increase of cancer risk if dysplasia is present. Then there's a problem about what is Barrett's esophagus. Now, it is all defined as a columnar line esophagus. Is it the endoscopic viewing of the Barrett's, endoscopic viewing of the columnar epithelium we call Barrett's, or is it a histological diagnosis? So by histological diagnosis, I mean Alcian blue staining or the presence of goblet cells. So if you endoscope the patient, 23.3% of the patients will have Barrett's who have had reflux symptoms. However, if you take biopsies, it's 14.1%. So it is one of the great difficulties. How do you define Barrett? Is it based on endoscopy or is it based on biopsies? I think most people agree it's probably biopsy driven, but equally what happens if you see Barrett's esophagus at endoscopy? Do you put them through surveillance even if the histology is negative? These are difficult questions to answer. Now the screening again, therefore the screening becomes controversial. There is certainly an association between gastroesophageal reflux disease symptoms and esophageal cancer. And we know from Lagran's study that patients with long-standing reflux symptoms are 43.5 times higher to develop esophageal cancer. And if you look at people undergoing gastroscopy in the Western world, 10 to 15% of them will have Barrett's esophagus. And others who have endoscopy for other reasons may also have Barrett's esophagus, although they may not have symptoms. That's up to 1 to 2%. If you look at the Asian population, it's up to 5%. However, it's very important to remember that risk of cancer for an individual patient with reflux symptoms is very low. So what is the aim of doing Barrett screening? It is to identify low to high grade dysplasia prior to developing adenocarcinoma. But the problem is that most patients who present with the esophageal adenocarcinoma, at least in the UK, have no prior evidence of gastroesophageal reflux disease or Barrett's esophagus. Their first presentation is advanced cancer. The second problem is that how good is the Barrett surveillance program? People who are on Barrett surveillance program, again, present with adenocarcinoma. I mean, if your Barrett surveillance program is great, then you should catch it at the level of dysplasia. But some patients do present with advanced cancer in spite of being on a Barrett surveillance program. And also, there's no evidence that any screening actually improves overall mortality from esophageal cancer. On the negative side, of course, once the patient is on a surveillance program, the patient overestimates the cancer risk, hence anxious, has a poor quality of life, and of course, you get increased insurance premiums because of cancer risk. Now, if you look at the histological diagnosis of dysplasia, it is well known that low-grade dysplasia is overdiagnosed. And concordance between two pathologies can vary up to 30%. I mean, they will disagree quite a bit. And one of the studies, some interesting study they did was they gave the same specimen to the same pathologist on 2 different dates and find that 20% of the time he disagreed with himself or herself. Could immunochemistry reduce the variability? It's possible. But there are these newer endoscopic methods coming, as you know, narrowband imaging, not new anymore, acetic acid instillation, and zoom techniques, and possibly confocal laser microscopy might improve the yield of dysplasia. This is what we are looking for. I don't know whether you read Nature recently. People think that artificial intelligence actually could diagnose Barrett's histology better than a pathologist. Pathologists could be out of job soon. So this was Nature recently in April. One of the interesting surveillance program might well be the Eso Sponge with biomarkers. Now these are sponges you just, you can do it in the community. It basically takes scrapings from the esophagus and may diagnose dysplasia. So you can do it in patients with long-standing reflux symptoms. They don't need to have an endoscopy as a surveillance program. This is not dissimilar to what the Chinese used to do 50 years ago. They used to tie rice in a plastic bag and ask the patient to swallow and pull it back. This was how they used to do surveillance for squamous cell carcinoma in northern China. So if the surveillance program goes well, then early intervention will bear dividend, because then you can do techniques that will have organ preserving treatment. We are talking about ESDs, EMRs. I'm sure the workshop yesterday would have done some of those, and radio frequency halo treatment. People are even talking about chemo prevention with vitamin D these days. However, there are risks of recurrence if the patient has got intestinal metaplasia and occasional cancer. Even with these interventions, there is no real evidence as yet that it increases the overall survival. Then the question is, could medical or surgical treatment, surgical anti-reflux treatment can reduce the risk of esophageal cancer in Barrett's patients? Stuart Speckler's study showed that there was no difference whether they are treated medically or surgically. If you looked at endoscopic surveillance versus radiofrequency ablation, we're talking about halo here, the two arms, there was reduced risk of neoplastic progression in the RF group, which you will expect that anyway. However, there is high risk of complications. A lot of the patients end up with esophageal strictures and hence poor quality of life. What they found was that there was no difference in mortality, although the study was only up to 36 months. And what about the mortality and life expectancy of patients with Barrett's esophagus? If you look at the life expectancy of a Barrett's esophageal patient, it's 81 years, irrespective of whatever you do to them. And the cause of death, only 4 to 8% die of esophageal cancer at the end of the day. Most of them die of cardiovascular or respiratory causes. And the incubation period for cancer from Barrett's diagnosis is up to 30 years. So it's a lucrative business for gastroenterologists, but does it actually improve outcome remains to be seen. I thought I'll talk about something about the National Esophageal Gastric Cancer Audit. I think Chaturanga is very aware of this. In the UK, we collect all data. So this is the data on high-grade dysplasia. So all patients with high-grade dysplasia in the UK are now discussed at our MDT, and they are all logged and audited. So what's interesting is that out of the high-grade dysplasia patients, only 59% come through the surveillance program. The 41% are new presentations. Often the plan for endoscopic therapy, this is the whole of UK, is 74%. But they do find that 1 in 2 patients are not even fit for any active treatment because they are elderly, although they are in Barrett's surveillance program. What about the outcome of endoscopic treatment in the UK? So only 76% had complete excision. Of those, 31% had cancer cells. So the diagnosis, it wasn't high-grade dysplasia, it was in fact invasive cancer in a significant group of patients. And we also found that worryingly, the proportion of patients with incomplete excision doubled since the previous study, from 2015 to 17. So of these patients, 50% had to undergo further ESD or EMR, 15% ended up with esophageectomy, others had further surveillance, and some underwent further ablation therapy. So to conclude, the long-term reflux symptoms and Barrett's esophagus are associated and with the development of esophageal adenocarcinoma. I think the value of endoscopic surveillance remains uncertain, although once you start a surveillance program, you can't stop it. The histological diagnosis for low-grade dysplasia needs improvement. I think the AI might be the way to go here. The treatment of Barrett's esophagus itself does not affect the disease progression. So this is the challenge. Could there be any new treatment modalities that might change this? So on that thought, I shall stop my talk on that and happy to answer any questions.
Thank you very much, Sri, for your excellent talk. And I'm sure it gave us a lot of insight on Barrett's and the way of your, even though you are a surgeon, and the way you approach a case is case-based and it's different. And that's the thought process it's given to us in teaching. And so you think it's Barrett's is overdiagnosed, or?
No, I don't think Barrett's is overdiagnosed. I think it's the definition is the problem, because I think the problem can often be the pathological interpretation, because I think endoscopically Barrett's is better diagnosed, I think, personally. The histology, the problem with the histology is where you take the biopsy from and how it is interpreted. I mean, I do remember in the early days, they say, if this biopsy was taken from this place, it's Barrett's. I mean, that's sort of slightly strange kind of report, you know. I think AI for histology would be the way to go, I think, because the problem is the low-grade dysplasia diagnosis. And because if one can nail that, then one can then give the treatment, endoscopic treatment, and therefore avoid any major surgical intervention.
Anyone in the audience, if they have a question, they can ask. And also in the peripheral centers, they can send a text to us so we can ask the question. So Sri will ask any more questions end of your next talk as well. So then, next talk will be done by the same person. And Mr. Kadirkamanathan is the best person to talk about this topic, as it's about minimally invasive esophageectomy and overview. He did this great job in Broomfield Hospital, Chelmsford, Essex, and he's the pioneer in actually minimal invasive esophageectomy. It's done, he started laparoscopically and he moved to robotics as well. And he has trained many of UK and even our trainees to a level of excellence. And I'm happy that I can introduce him again in this talk because he's the one who trained me. I have done about 60 to 70 esophagectomies, minimally invasive, because of him and his team. So please, Sri, please give your overview on this topic, minimally invasive esophagectomy.
Chaturanga, thank you once again. I mean, just to say that we set up the cancer center at Broomfield in 2003 when I went there from the Royal London Hospital, from a consultant being there. So I think what I'm going to give an overview of what we did at Broomfield in Chelmsford, what were our results, and the history of esophageal cancer surgery from the beginning and where it's going and where it might go in the future. So esophageal cancer was diagnosed in China over 2,000 years ago. In fact, they actually built a temple for esophageal cancer. It's called the God of Throat or something like that, which got destroyed in the last century. It's the sixth most deadly cancer. The incidence is increasing year by year. And the overall survival, I'm not talking about the surgical outcome, but overall survival of all patients with esophageal cancer remains low. And in reality, esophagectomy remains the treatment of choice for potentially curable patients who are fit. And that's the key to that. Surgeons are adventurous animals. In 1846, the introduction of anesthesia created opportunities for them. And the first successful thoracic esophagectomy was performed by Franz Torek in New York. And you'd be surprised to see, I was reading history. I think I always told Dr. Kadirkamanathan that one should read history because one learns a lot from that. This particular patient had excision of his thoracic esophagus. Then he had an external tube fitted from his cervical esophagus through the abdomen into the stomach. So in other words, the conduit was a rubber tube, and he survived 13 years. Since then, you can see how the esophagectomy has progressed to Ivor Lewis performing right-sided esophagectomy in the 1940s, McEwen in 1976. And in fact, these guys did their surgery in peripheral hospitals, not in main teaching hospitals. I think Ivor Lewis was in Middlesex Hospital and McEwen was somewhere in Darlington or Doncaster, I can't remember. In 1992, Alfred Kusheri developed what we call the hybrid esophageal resection. This was the first move towards minimally invasive surgery. I mean, he did either thoracoscopic open abdomen or laparoscopic open chest. In 1996, Lukatich performed the first minimally invasive esophagectomy total. In other words, laparoscopic, thoracoscopic. I mean, it's hard to believe it's now, gosh, 24 years since minimally invasive surgery came about. And in 2002, the first robotic minimally invasive esophagectomy was performed. So we are nearly 20 years gone even from that. So if you look at the UK, one performs 4 kinds of surgery: Ivor Lewis esophagectomy, 3-stage McEwen's procedure, left thoracoabdominal esophagectomy, and transhiatal esophagectomy. If you were to look at minimally invasive surgery, this is the definition would be that it's totally minimally invasive, i.e. thoracoscopic and laparoscopic, or robotic. And in reality, we only perform 2 kinds of surgery, either Ivor Lewis or McEwen's procedure with 3-stage with anastomosis in the neck. There are 1 or 2 papers suggesting robotic transhiatals, but they are not in the mainstream. This would be interesting from a Chelmsford perspective. We started doing, this is before my time, in fact, 1992, my senior colleague, Mr. Harvey, did open Ivor Lewis esophagectomy, but believe it or not, he did his first totally minimally invasive MIO in 1992. It took him 12 hours, and he didn't do another one for years. But he did do one in 1992, and the patient survived and did well. We did transhiatal esophagectomies in 2003 when I came to Chelmsford, And we soon developed hybrid esophagectomies, what Sritharan mentioned earlier on, with a laparoscopic approach to the abdomen and open chest. And we moved on to MIO on a more permanent basis in 2015, although we had done some cases prior to that. And we did the first ever robotic esophageal, totally robotic esophagectomy in 2016 in Chelmsford. And up to 2018, we had done about 300 resections with a anastomotic leak of 7.9 and a hospital mortality of in-hospital mortality of 2.7. I think I look at in-hospital mortality because with a excellent ITUs, most patients can survive up to 30 days. So I think when you look at data, I think one should look at in-hospital mortality or a 90-day mortality these days. And we published this paper a long while ago, in fact, when we looked at our hybrid esophageal resections, 169 patients, out of which 61 had recurrences. Their symptoms are shown on the right. They survived 90% up to 1 year, 60% up to 3 years, and 5 years survival was 48%, which is not bad at all. So again, I'm going to go back to the knockout because in a way, the National Esophageal Audit tells us what's happening currently in the UK. So this is data from 2016 to 19. The report was produced in 2020 last year. It involved 4,000 plus esophagectomies, and the most cases were Ivor Lewis. There were 86% Ivor Lewis, and the others were in a small percentage. And the median length of stay was 11 days. If you look at the lymph node harvest in this particular group of patients, it was over 15 was the number they looked at to see whether this was a radical surgery or not, and it was 88.4%. So a lot of the cases were either 2 or 3 field lymphadenectomies. Slightly disappointing was the longitudinal positive resection margin. It was 4.2%. You wouldn't expect an esophageal resection to be that high. The circumferential positive margin was nearly a quarter. Now, this may reflect either poor surgical technique or very advanced cancer. The 90-day mortality was 3.7%, and up to 3 years survival was 63%. But this is an interesting one. If you look at what surgical approach was used, even now, only 15.5% of cases were done totally MIO, be it robotic or laparoscopic. The hybrid was about 28%, and over 50% still undergo open esophageal resection in the UK, that is. If you look at what made minimally invasive surgery possible, a few things really. One is anesthesia, ability to have, comfortably have a prone position and deep neuromuscular relaxation. And we have better optics. When I spoke to Mr. Harvey later on, when he did his first MIO, he could barely see because optics were not that great in 1992. Now they are so much better. We do 3D laparoscopy most of the time in the UK. And better surgical instruments and sutures like V-locks, etc. And the energy devices. And better training, because minimally invasive surgery lends itself to better training because you can actually teach much better than open surgery. I also put the emerging rule of ICG. Now, this is slightly controversial in the sense that it looks at the blood supply of the conduit. Would it prevent anastomotic leak? Not entirely sure, but when you do robotic surgery, you can actually inject indocyanine green and you can actually map the blood flow. And of course, the Da Vinci robot, again, helps with minimally invasive surgery. I think when one does minimally invasive surgery, the goal should be no different to open surgery. It should be as good as open surgery. It should be as radical. And the outcome with regard to immediate post-operative period should be similar. And the likelihood it will be better, but it should be similar. Now, this should be to look at complications, anastomotic leak rates, in hospital mortality. And the survival has to be compatible or comparable to open procedure. So if you look at the pioneers of minimally invasive surgery, this is Lukatich's own paper. I mean, he did his esophagectomy from 1996 to 2002. He had 222 patients. They were all intrathoracic anastomosis. The conversion rate was 7.2%, and the median stay was 7 days. It was pretty good. And he had a very good 30-day mortality. Had a slightly high anastomotic leak, but overall, the results were spectacular, to say the least. Then people looked at comparing minimally invasive transthoracic esophagectomy, either laparoscopic or robotic, and compared it with open surgery. The problem here is that it's meta-analysis. It is not a randomized study. What it showed was that, not surprisingly, there was less blood loss, lower pulmonary complications, shorter hospital stay. In fact, the lymph node yield was much higher than open surgery. There was no difference in mortality, and there was some improvement in long-term survival, 1 to 5 years. So all these are good news with regard to minimally invasive surgery. But one interesting note was that there was a higher incidence of diaphragmatic hernia in the minimally invasive group as opposed to open group. Couple of things to say. I mean, all you guys know a lot about how to sort of set up patients before surgery, improving their preoperative status and so forth. But one of the things that's coming in our orgies and our meetings is muscle mass. So it's not the weight that matters, it is the muscle. So sarcopenia is a poor indicator of outcome following surgery, be it open, be it laparoscopic or robotic. And similarly, in the perioperative optimization, we talk about active cycle breathing techniques, ERAS. And one of the controversial things these days people are thinking about is that whether one should start oral feeding from day one. And it appears to have better outcome. And again, post-operative management, a lot of the stuff, all you guys know very well. But one of the things that has changed the game, especially in the minimally invasive surgical era, is the Eso Sponge. Now, this is for the management of anastomotic leaks. I'm not sure you're aware of this or not. It's a sponge that can be placed into the defect. At endoscopy, you need to have a very good gastroenterologist for this, and then continuous suction, and the anastomosis leaks will heal. Very much better than putting stents or anything else. So the next question is that in a lot of the places in Sri Lanka, I think a lot of the anastomosis is done in the neck rather than in the chest. Does it really matter? I went through literature. I was curious about this. In fact, whether you do cervical anastomosis or intrathoracic anastomosis, it doesn't matter in terms of whether they get dysphagia, dynaphagia, or overall health score. So cervical anastomosis is as good as intrathoracic anastomosis. Now, what about clinical outcomes with minimally invasive surgery, robotic versus laparoscopic? Again, we go to meta-analysis, and there are no randomized studies. 21 studies, 9,000 plus patients, similar outcomes. Robotic surgery took longer, not surprisingly. They suggested there was perhaps a slight increase in disease-free survival in the robotic group. There was certainly less pulmonary complication in the robotic group. However, there are no data on the quality of life post-surgery. So robotic versus laparoscopic, further meta-analysis, better lymph node harvest with the robotics rather than laparoscopic. Again, this is not surprising because robotically you can be much more bold and taking more lymph glands and less pulmonary complications. If you looked at with robotic, with open surgery, there's no comparison really. I mean, robotic surgery wins hands down in terms of blood loss, wound infection, pulmonary complications, and number of lymph nodes harvested. So this is to mention trials. There are all sorts of trials going on right now. The Romeo study, which looks between open and minimally invasive surgery. the reverse study, robotics versus minimally invasive surgery. This is in China. Then the MIVAT study, MIO versus left thoracoabdominal esophageectomy, and Robot 2 study, RAMI versus minimally invasive surgery. So this is that there are a lot of people doing a lot of trials, but I might put to the panel whether they are surgical practice based on any randomized trial ever they have read. Surgical trials, by and large, are very difficult to do. I remember many, many years ago, there was a trial between open versus laparoscopic cholecystectomy showing that there was no difference. Similarly, open versus laparoscopic anti-reflux surgery showing no difference, but nobody does open surgeries anymore. Yeah, I'll be interested to see how these pan out, because one of the recent August talk I went to a couple of weeks ago suggested that there was no difference between open and minimally invasive esophageal resection. So I think I'm going to summarize by saying that there's no doubt, in my view, minimally invasive esophageectomy is gathering pace. Now it's 20 years plus. I think this will become the gold standard in the future. It's already happening anyway. I think early diagnosis, patient selection, and good preoperative workup is very important. I feel that laparoscopic surgery may well be replaced by robotic surgery in the very near future. So you see, in Sloan Kettering in New York, they only use laparoscopy for diagnostic purposes. All surgery, complex surgery is done robotically. But ultimately, any endpoint of any intervention must be patient outcome. So cancer cure is nowadays given. So one must now look at quality of life. Now, if you look at Demester's paper, quality of life recovers to normal levels, takes up to 10 years after esophagectomy. So how can we make that better? I mean, that's one of the challenge for you guys. And in my view, ultimately, I think early diagnosis is important. The ultimate goal has to be organ preserving surgery, because that minimizes all the problems of reflux, delayed gastric emptying, etc., which are associated with esophagectomy. Thank you.